Nice to see everybody. If you could put your name and your agency um, and where you are, where that would be great. I see familiar faces. We're gonna give it maybe, I don't know, just a minute or two, and we're gonna get started just so we have time. Super exciting to see everyone. I love it. Fun. So fun. I'm just gonna hang out here with you all day if that works. No. We all have busy days, I'm sure. Okay, I'm gonna get started. I'm actually just teeing us up here this morning. My name is Elizabeth Estes, and I'm the founder and executive director of Breaking Barriers. And we're just super excited to be doing this webinar this morning with some partners that came to our symposium this year, and that have been working on an incredible innovation in Monterey County to better serve and support children, youth, and families there. And we will be doing more of these forums where we can really elevate innovations and programs that people are building a lot across California to better integrate service delivery systems for children, youth, and families. So I'm really here to listen and learn as much as the rest of you are, and to elevate this amazing work. And I'm going to be turning it over to Monterey and Deryk Brunt from CredibleMind to really do the presentation. We're going to ask you if you have questions to put those questions in the chat. And the presenters will be working on getting answers to you. And we may also be doing some sort of follow-up work to get answers to you on questions. And one thing I just think I'm always telling people to think about, particularly in Breaking Barriers work, is a lot of our work is innovation. It's moving the needle to a more holistic service system, ecosystem for children, youth, and families and adults. And so think about that as you're listening to this, and potential adaptations even to the work here for other populations, because that's the lens that I often bring to work like this, and innovations like this. So with that, I'm going to turn it over to Deryk to kick us off, and just really thank you for being here.
Thank you, Elizabeth. Great to be with all of you this morning. So welcome to this Improving Community Health Through Screening and Triage presentation and discussion. I hope you do have questions and drop them into the chat. Let me just do a little orientation here. First of all, a couple of introductions. I'm Deryk Van Brunt. I wear two hats. I teach at UC Berkeley in the School of Public Health, and I'm one of the co-founders of CredibleMind. I'm joined by Wes Schweikhard, who's at Monterey County Behavioral Health, and he'll be talking in just a moment. Also joined by Brittany Ganguly, who's with the CalMHSA, as you know them, and Shimar Clements, who works with me at CredibleMind. And here's basically what we have planned. Let me kind of give you a little bit of the bottom line up front. There's been this amazing innovation project in Monterey County. You see sort of an alphabet soup at the bottom of the slide here, and the quick history is that funding that came through the Mental Health Services Oversight and Accountability Commission went to CalMHSA in a project called Help at Hand around how to innovate to improve behavioral health services and access in California. And Monterey County teamed up with CredibleMind and put in for a request for proposal for funds. It got funded. A system was built, which I'll describe in just a moment. A formal third-party evaluation was conducted, and that's what we're here to tell you about. So, essentially what was built is a digital platform to streamline the behavioral health intake process. As you'll hear, Monterey County was getting increasingly large caseloads and overworked staff, and feeling at the same time, even though they were so busy, that they weren't actually getting as much outreach to the community with people that really need help. And so they wanted to figure out, is there a way to leverage technology? Well, we'll give you the results later, but they tripled access. They reach populations that have been very difficult to reach. And it's really exciting for us to share this with you because now other counties and organizations in California can start leveraging this digital platform to see if it can help you with projects and challenges that you have. So here's our workflow. Wes will kick us off with a description of the Behavioral Health Bureau in Monterey County and the challenges they had and the innovation process they went through. Shimar is going to then talk about what was actually built and the results of that utilization, these kinds of things. I'll give a brief update on this third-party evaluation work that was done by UC Berkeley, unrelated to me. And then you folks are really lucky because CalMHSA and Brittany is going to talk about how if you have interest in this project, the state is here to actually help you think through the applicability for your community. So there's some assistance available to you, and even possibly innovation funding, if if you line up and have funds available. So without further ado, we're really excited to share this with you, and let me turn it over to Wes.
Thank you, Deryk. Hello, everybody. I'm Wes Schweikhard. I'm a management analyst with Monterey County Behavioral Health, and I serve as the innovations coordinator. I'm here to give you a lay of the land in Monterey County. And so Monterey County Behavioral Health, we are the safety net provider in Monterey County. And so what that means is we serve Medi-Cal eligible recipients and uninsured individuals, and more specifically, individuals with moderate to severe mental health acuity needs. Anyone on private insurance or with less severe needs, we refer out to our many partners. And our bureau is organized in a way like the graphic there on the right side, where we have 5 arms essentially to our bureau: adult system of care, children's system of care, substance use disorder services, and crisis services. And then there's access to treatment, which is sort of acts as our front door. Anyone can enter at any point in our system, but access to treatment encompasses our 4 walk-in clinics spread throughout our geographically large county. That's really the front door. We consider the front door to our system. And for reference, in fiscal year 22-23, the number of clients we served was almost 13,000, with the average service value of almost 9,000, and number of new clients within that being 4,071. And that's pretty typical of in recent years of our turnover rate in new clients. And then so this project, WellScreen, came about as an innovation project around 2018 or so, when demand over the preceding years, demand had really increased a lot while our staffing remained the same. And so we're kind of feeling a bottleneck in our access to treatment system of care in particular, where more people are coming in the door and not enough providers to take them in comfortably. And so we wanted to create a tool, leverage technology to help this situation. And it says the solution would be to create an online screening and referral tool that identifies potential mental health conditions and connects users to relevant local and online resources. And so our aim was kind of twofold: is to help kind of efficiently direct people before they were to come to us. Because again, if somebody has less severe needs or they have private insurance, we're going to refer them out to elsewhere. And so, if this tool can kind of catch that early on and help people find their way on their own, that would be great. And then also, as they go through this screening tool, they get their results of potential risk factors. And we were wanting those results to help bring efficiencies to that client intake process, if possible. You can go to the next slide, please. So some more background on Monterey County. You can see here in that graph, I mentioned the innovation planning came about around 2018. So you can kind of see it was steadily climbing up until we put forward the innovation plan. And I'll add to that, the innovation plan was to become a part of the Help at Hand collaborative with CalMHSA, and develop this unique custom tool, which and we'll get to it eventually. But yeah, through the process, we landed with CredibleMind, which has been great. And so yeah, so the lead up to the innovation planning, our demand was increasing. Since then, our client count has sort of plateaued, but at the same time, we felt more strains on our capacity among providers. You know, and COVID was a big part of that, caused some burnout. And then also sort of encompassed in this whole challenge and background and context and everything is that Monterey County is pretty geographically large, with several communities of 15 to 30,000 spread out, about 20 to 30-minute drive from each other throughout the county. And then there's some even more isolated pockets down in southern Monterey County in particular. Next slide, please. And so, yeah, sort of speaking more to the background of what we're experiencing. I kind of alluded to it earlier with that bottleneck, but you know, with more people coming in the door, but our number of providers remaining the same, and also yeah, clients just coming to us from the outset, maybe not really understanding that they had private insurance, or they not knowing their severity of needs. You know, we found that 53% of our service minutes in our access to treatment system of care were for assessment and evaluation minutes, and also linkage and brokerage, i.e., you know, time spent referring out, versus 26% being allocated towards treatment services. And so we wanted to alter that ratio a little bit, you know, and enable more time to be spent on treatment services. And then again, with the challenge here is the community not being aware of other local resources available to them. The next slide, please. And so we put forward the innovation plan to build a custom tool for Monterey County, and kind of add it into the buffet of options that the Help at Hand collaborative was going to offer. And we wanted to build this screening and referral tool that could identify potential behavioral health challenges and connect users to relevant local and online resources, with the goal of increasing community engagement, awareness, and access to local behavioral health resources, improve efficiencies in the referral process, and also the assessment and intake process, and generally promote early detection of mental health symptoms, especially among community members who are traditionally underserved and geographically isolated from services. And I'll turn it over to Shimar from here.
Thanks, Wes. So as Deryk mentioned, I'm just going to go over what the solution actually looks like so people can get an orientation to how we address the needs that were coming up in the county and the solutions that can be provided to your geographic areas. So in November 15th, 2022 is when we launched WellScreen Monterey. We already talked about, you know, some of the funding and partnership models, and we'll get more into that when Brittany speaks about what that can look like moving forward. But first, I'll just direct you to the screenshot that's there. That's what the website looks like. We have a very beautiful, very accessible website that allows people to come in and see the invitation to start working on their mental health through this screener. It is bilingual from the start. Whether a person is using their browser in English or Spanish, they can be able to access the information in their own language. And we have some things that I'll highlight, such as the Need Help Now button at the top, which allows people to access emergency crisis information, both local and national hotlines and text lines and things like that. If, you know, going through a 15-20 minute screener isn't something that they have capacity for in that moment. We also just have ways for a person to access the local Monterey County resources without going through the screener, where they can just see a list of the local programming that's available in their area. We have FAQs, and then again, the invitation to take the screener. And then beyond that is, if someone has already completed WellScreen, they can come back and access their results with the results code that provided for them at the end. That allows them to look back at the results and also share those results with community members, mental health professionals that they're working with. Might be a teacher, might be some other type of mentor support system for them. That's a very unique feature that we hope can increase the information sharing along a person's support team. So with the screener, like I mentioned, it takes about anywhere between 10 to 20 minutes to complete. It screens for conditions such as anxiety, depression, postpartum depression, symptoms of trauma or PTSD, bipolar symptoms, psychosis symptoms, eating disorders, and substance use. And these things were defined and refined by our needs assessment with the county. They can be augmented to meet the needs of your area. We are using standardized screeners that are already publicly available, such as the PHQ-9 for depression or the GAD-7 for anxiety, and allowing people to, we have that validated basis that is being used to screen for these various conditions. Again, available in English and Spanish, and it's anonymous and confidential. People do have the opportunity to sign in and create an account on the website, which will make it easier for them to re-access their results or any resources that they share, that they save. But also we wanted to eliminate the barrier of stigma, of shame or embarrassment, of confidentiality, so that people can come in and not have to provide any personal information, and go ahead and start on their wellness journey. With the anonymity and confidentiality that extends into that results code, people's personal health or personal information is not available on their results. It is a 6-digit code, and as long as they share the accurate numbers and letters, that person that they share it with can see their information without there being any like HIPAA considerations or issues with sharing personal information. So once someone makes it through the entire screener, this is a bit of what they'll see for their results. So first, there's a summary that's going to break down the various conditions into areas that they're doing well, areas of some concern, and areas of greater concern. When you click on any of those areas, it will open and expand into a larger description of what's going on and how they actually scored on the specific scale, which we'll show on the next slide. Beyond that, the what to do next is customized to a person's results. So they'll either see, especially if someone has scores for multiple areas of higher acuity, they will see an invitation to call Monterey County Behavioral Health directly, or to call the substance use services side directly if that's what they were scoring into. We are trying to make the information very accessible by easy clicks to call, especially if someone's taking it on their phone. It will automatically just, you click on the number, it calls for you. You can see the locations and hours of the services if you want to walk in person. And then there's still that results code that you can copy, email to yourself, text to yourself, so that you can save that information to share with others or to re-access yourself. And then this is the example of the further information. So one of the first steps that we want to empower people with is this area of psychoeducation around providing people who may not have had any real experience with mental health support, the language to understand what it is that they're experiencing and how to advocate for themselves when they're going in to talk to someone about it. Or even if they decide that's not what they need or not what they're ready for, have the vocabulary to further search for information that's going to be most applicable to what they're going through. So at the top, you can see that the scores are along whatever the scale is, and the person can easily visually see how they scored. Get some information. This is for a PTSD symptomology. They get some information on what that actually looks like in layman's terms, in the practical sense, day to day, how those things might be manifesting in their life. A little bit of information on common ways to address those needs and concerns and where they can go. And then lastly, is the link outs to resources. So these lists are customized to the specific symptom acuity level or risk level rather, and to the specific condition. So for this one, we have a list of first local trauma support. So things in Monterey County that a person can utilize to work on this specific area of their mental wellness. And then we also CredibleMind, our specialty is linking people to evidence-based self-help resources. So that next list would open up into things like podcasts, apps, articles that are specific to dealing with trauma responses. And then for this one, we also added abuse and neglect hotlines, as those are often some of the precipitators of PTSD and trauma, and all that information is readily available and again, tailored to each of the different condition areas that someone might screen into. And so we'll just talk about some of the results. Between November 15, 2022, when we launched, to May 7, 24, we've had over 41,000 visits to the site. Completions are of the screener, we're at about a 57% rate. So people who come in, they are going through the whole 10 to 20 minute screener. We have many people, young people coming in, seeking out information. We have many people of Latine origin, Spanish speakers who are utilizing the site. Some of the things I also want to highlight and I think are very interesting are that 94% of the people who are completing the screener never receive services from Monterey County Behavioral Health, so that's expanding the reach there. But then also 86% have never received behavioral health treatment or services anywhere. So these are people that might not otherwise get reached or may not otherwise take the step to get support or have some type of tool that can help identify things that they may really be challenged with. One of the perks of this site as well is just a data collection for the county. It can give a lot of insight into what's going on in your community. And we do a lot of sharing of results on a global level, obviously not an individual level. And so the last bullet point shows that in one of our questions, we ask of people, like, what are some of the factors that you think are most impacting your mental wellness? And physical health, employment, school, and family instability were some of the things that were most identified in Monterey County. And that information can further support the county in supporting their community. And then this is just a breakdown of some of the results that we're seeing in the various condition areas. So you can take a look at the things that may stick out to you. Some things that I'll highlight are, again, I mentioned in the beginning that we tailored the types of conditions that we're screening for based off of the needs assessment we did with the county. So initially, eating disorders and postpartum depression were not included as the initial intended conditions for the screener, but we added those in. And as you can see, we've identified a significant need with over 550 people screening in from moderate to severe postpartum depression, and over almost 8,000 people showing risk levels for eating disorders. You can also see on the right side some of the breakdown for substance use, and a lot of people might come into an office because of a substance use issue and not realize they're also having depression or PTSD or vice versa. And so this helps people get a more comprehensive overview of some of their risk factors. And with that, I'll pass it on to Deryk to talk about some of the impact based off of the evaluation.
Shimar, thank you. So, it was clear that, Monterey County was increasing access and reaching populations that are not easy to reach. But of course, they wanted some real formal evaluation around this. So a group out of UC Berkeley, Health Research Group, did a 1-year evaluation of the program. And there's a 168-page report for anyone who doesn't have anything better to do over the holidays. No, but there is a 4-page summary of that report. And this is a 1-slide summary of the 4-page summary. And essentially, it's really rather remarkable. So the county has seen that they've tripled the number of people who have accessed county mental health support, meaning whether it's face-to-face services or whether it's online support, a better understanding your risks and connecting to resources, they are thrilled with this idea of increasing, as was one of their goals, just access. And then the second and third bullets are the people that they're reaching, groups that are traditionally very difficult to engage, people that are not receiving services anywhere, people that have moderately to high severe levels of risks, and then of course youth. Everything from age 15 to 24 represented more than half of all the users in the system. And that's of course a very formative time for people, and was another goal of the county to try and get in and find youth as early as possible. And throughout all of this, the costs actually went down in the county. And I want to pause here and emphasize something. We are not this group here on the Zoom with you. We're not claiming that this digital behavioral health platform reduces costs. That's, I don't think, the way to think about it. But I think the way we would say it is that if a community can greatly increase access, reach hard time, being reached, support large numbers of people with self-care, connect them to resources in a more efficient way, help the administrative intake process with more efficiency, and not increase any costs during all of that, that's a home run. And that's what we're really excited about. So let me float out a little bit higher level for a moment. We've been talking about just this case study in Monterey. And what I want to do is take a step back, because this is in the context of a larger opportunity for communities here in California. So WellScreen, the name of the system that we've been describing, has been tested in Monterey County. And there's going to be continuing, ongoing innovation and new things that we want to do. And that is now available to other communities in California. And that first bullet where it says CredibleMind Smart Screen, that WellScreen and Smart Screen are essentially the same thing. They're not identical, but close. And that's what we've been talking about. But on the digital platform, on this technical platform, there are 2 other products that we have not talked about today. And I just want to give you a sentence or 2 about each, so that as you think about your community, you're aware of a larger opportunity, which is there's also a self-care program. And what that is evidence-based self-care for over 100 mental health and well-being topics. And typically you would think of the WellScreen or Smart Screen as one portal in your community to allow people to come in on their phones, on their computers, and be able to quickly find the right resources, or just see what their risk levels are and if they need resources. The self-care program is more of a separate portal. It allows you to come in and just start immediately looking for self-care. It doesn't assume that you're actually looking for services to begin with. It may be that you just already know you're not sleeping well and you're looking for evidence-based tools to help you sleep better. So that's the second bullet. The third is that we've recently put together a flourishing program. Everything that we talk about in mental and behavioral health, we try desperately to not have talk about this with a negative framework and negative language and creating stigma, but we keep on using the same language. And the question is, how do we shift this conversation over time to something more positive? How do we really engage people with understanding how to be happier in their everyday lives. There is a science to happiness. The general term of art is flourishing. And so based out of a program pretty much out of Stanford, we've created an online self-paced program to help anyone in a community or everyone in your workforce go through this program and create their own flourishing plan that's science-based. And the feedback that we get is, brings tears to your eyes on how it changes people's lives. So all three of those are available on a platform that you could be leveraging in your communities. And together, the way we think about this is, as a country, we need to move from a reactive system of care around mental and behavioral health to what we might call a population-based system of care, which means we've added much more prevention and early intervention, as well as the navigation to find services so that people can connect to the right resources for them. Of people with mental distress, 3 out of 4 are not looking for professional help. They just want to know what they can do. And 1 out of 4 is looking for help, and let's help them find it. When we put these pieces together, you've got everybody covered. The last thing I wanted to mention is we've mentioned this is available currently in English and Spanish. The self-care platform is already in 25 different languages, and SmartScreen can be expanded as well. So as we're all tackling issues around health equity and access, creating language support for communities specific to your geographic area is something that we can do. And the last thing I want to share with you is that the president of NACCHO, the National Association of County and City Health Officials, said something very interesting, Lori Freeman. And she said, public health and behavioral health need to start working together. Often public health thinks of mental health as just a behavioral health issue, and behavioral health thinks of prevention and early intervention as a public health issue. And if we keep thinking that way, we're never going to find the middle. So we need to pull public health and behavioral health together, along with all the coalition partners that you would expect, education-based systems, human services, insurance companies in the local area, hospitals, United Way's foundations, et cetera. And we need to come together and work on this population-based approach. And what this platform is a place where people can start leveraging all of this with different portals and then get their own organizational needs met. Okay, that was kind of motherhood and apple pie, a little high level. Just wanted to give you the big picture. Let me turn this over to Brittany, because for those of you that may have an interest in this WellScreen system, there is assistance available at the state level, which is wonderful. So Brittany, welcome.
Thanks, Deryk. Hi, everyone. So I'm Brittany from CalMHSA. If you're not familiar with us, we are the California Mental Health Service Authority. We're a joint powers authority, so we work with every county and city jurisdiction throughout the state. So counties are our members, and then we support their behavioral health or mental health departments with a wide number of initiatives, program management, and support throughout their system and service delivery. So what we did is Wes was speaking about the Help at Hand program. So CalMHSA was the program manager for a large statewide innovation program, which started in 2018 and just wrapped up in June. So it's a 5-year innovation program where counties could spend their MHSA innovation dollars on exploring what mental health apps looked like in integrating into their system of care. So Monterey's participation in that was the development of the WellScreen tool for their county, and CalMHSA's support came in many ways, from overall program management to contract management, and supporting Monterey's work with the various vendors involved in the project. And so we are here for the same thing, to continue providing support in the same ways. So as you might be hearing this and thinking about, how would we do this? CalMHSA is here. So basically we can support with, if you're interested in doing, using this product or tool, we're here to help think through that from a big picture perspective. So if there's multiple counties who might want to do something like this, we can coordinate a multi-county project. There's definitely benefits from that collaboration amongst one another. We bring technical expertise, obviously, from our experience with Monterey and having done this with them and working closely with CredibleMind. And we also provide a fiscal intermediary and structure. So a lot of times the contracting will go through CalMHSA, where as a joint powers authority and thus sort of quasi state entity, that's the benefit we bring to counties, is that the contracting through us and work and negotiation with the vendors is much easier than oftentimes the month-long process through the county system. So I'm really here just to hear your interest, either today or in the future. If you are interested in this, we'd love to hear from you. We're speaking with a number of counties, and at this point just trying to understand who might be interested in what in terms of using the tool, and then can formulate some plans from there in terms of how CalMHSA can support, and if there's one-off counties, okay, you would like to use it this way, or if there's similarities between counties, and we can sort of orchestrate what that looks like.
And Brittany, I'll just advance a slide here. So you have Brittany's contact information right there on the slide. So if you want to take note of her email address, or you can ask the Breaking Barriers folks as part of the conference follow-up. But please feel free to reach out to her for any potential assistance or just to better understand the services that are available to you. If you have, I'd call it more technical, the platform questions, is it available in this language or this or that? You also have the contact information, Scott Dahl from CredibleMind. So we built the platform itself, so you can triage your questions however you like. Just wanted to make sure that you had both groups available to you. So
one other thing, sorry, Deryk, one other thing I forgot is, just as you're thinking about this, we see potential for county behavioral health departments. There's still an opportunity to use your innovation funds. We know Prop 1 is starting, but not until July 1st of 2026. So we've spoken with the OAC, and this is a great way to utilize innovation funds between now and that Prop 1 era that will start. So just throwing that out there, we think that's a way in which counties can leverage funding for this project. We know many folks are trying to think about the best use of their MHSA funds right now. So that's one path that we're exploring.
Very important. So let me stop sharing this screen. Let's open it up. Hi, everyone. We can see you better now. So let's see. I know we have some questions in the chat, and let's see if we can do this through chat. We have a sufficient number of people. If we completely open this up, it might be difficult just verbally, but let's see with the chat here. And Natalia, do you want to sort of drive, or how should we move into conversation?
I'm happy to drive if you'd like. I can also, so we have a few from the beginning, and thank you all for your questions. And if you have any more, you can still drop them in the chat. But the first, there's a couple from Michael Butler. Thank you for your questions. Is how did you conduct outreach tied to raising community awareness of this tool?
Yeah, I can answer that one. I had to make a little list because we did a lot of things while we still had innovation funding that gave us some flexibility, or more flexibility, I'll say. So we had done community outreach and marketing of the tool through Google ads, Facebook ads, bus posters, TV and radio commercials, newspaper advertorials, and then we did outreach to primary care clinics in the community throughout the county. It was about 75 or so, where we dropped off little stations, I'll say, of that had various resources for both the clinic staff to become familiar with the tool, and then also for clients coming into the clinics, they could grab a little card or a brochure on the tool as well. And then we also equipped local CBOs with tablets. So when they're kind of doing their various services out in the community related to kind of all things health related, and including behavioral health, they'd have a tablet on hand to assist anybody interested in accessing the tool. So those are some of the ways that we did outreach for this. And then as we shifted beyond innovation funding, and currently Monterey County is using prevention funding to sustain this program. We saw that Google Ads was kind of the big hitter in terms of effectiveness, and so we've continued to focus our more limited marketing funding on Google Ads.
And I think, Wes, if I'll just add that if we end up working with other communities around this platform and program, because there are services involved as well, we assign a account manager to work with you, and the whole outreach and engagement within a program for a community is part of what we work with you on. We have what we call a playbook, and it literally is, these are the different things that communities have done, because we work with communities around the country. We're in over 35 states now, and we're seeing things that are working very well to drive engagement and things that don't work very well. And obviously, you're entitled to drive engagement however you want in your community. Just letting you know, we show up as a partner and we tell you what we're seeing works. And that kind of best practice sharing is kind of, what comes with the program.
Yeah, and answering the second part of Michael's question too, that to what extent is the platform applicable to and used by children and youth? It was built for populations 16 and older, so really the TAY and adult population, and anybody accessing the site and indicates they're younger than the age of 16, they're redirected to a resource page that kind of lists a bunch of local resources that are available to them for that
Yeah.
age group.
And that was largely done because as an online self-screener, those validations are only available for certain age groups. Children are by and large not able to answer screeners in a way that's going to assess their anxiety, depression, things by themselves online. And so this is the access for this particular product because of those parameters.
And I'll just add two things. To the degree that there are screeners for younger people, they could be incorporated. And also, going back to that self-care platform, and I realize this can be a little bit confusing, the screener and the self-care, but there's a tremendous amount of self-care material for young people as well. And that's a whole different discussion around whether that's direct access or whether that's mediated through a parent or a counselor, but that kind of material exists on the platform.
Okay. We have a few more questions. There's one follow-up, and is this available for school districts directly? Like, can we bring the platform into a school district, or does it need to go through county behavioral health as a partnership model?
I'll take a crack at that, but please, anyone speak up. I think that might have more to do with funding than contracting. In other words, the platform is available for organizations and agencies to use it. And if a school system's interested, we certainly would engage and have that discussion. But I think it might make sense to think more broadly as a coalition in the community and include behavioral health. It also might bring some of the innovation funds. But technically, the answer is it could be done independently.
Yeah, and I'll just add, I mean, kind of related to what we just spoke about in terms of the age range this was appropriate for, or inbuilt for. I think working with school districts would be a little, maybe not totally appropriate.
Yeah, we'd have to think through
16
that
plus.
use case.
Yeah.
100%.
All right. We have another question from Sid Gardner. Thank you for your question. To what extent did outreach and access include veteran family members and persons affected by fetal alcohol spectrum disorders?
So with all of our MHSA planning, which this was a part of in our activities, we do engage our local Veteran Transition Center, and then NAMI and just a whole host of our community partners. So and we communicate with them regularly with what's going on. So they would have been engaged in that fashion, and including, and it's been a while, so I'm a little rusty on it, but like we in the development process, we did also reach out to a lot of our community partners to be a part of the focus groups and things like that to help inform the development of the tool. And I can't really speak to the fetal alcohol spectrum disorder. I can't think of if or how we would have engaged persons affected by that.
I think I'll just add one comment, which is, as the platform's been implemented and evaluated in Monterey, there were I believe, 8 screeners that we went through and listed. But we can add more screeners. That was just sort of the first project. You know, we're already aware of another 10 different screeners that probably could be added if somebody wants. So if you have a screener in mind, or even just a subject area that we can look in to see if there's a validated scale in that area, we're not limited by the number of screeners, by number of languages. We're not limited by many different things. So keep in mind.
Okay, thank you. I've got a few more questions. A few from Dana at Goal. Thank you for your questions. Is there data on what kind of insurance individuals who took the screening tool had?
Yeah, part of the data sharing that happens between the county and CredibleMind, that's part of it. That's one of the questions that we asked in the screener. So I just gave a quick look. I believe the date range on this is from launch, so November 2022 until today. And the highest categories for insurance are Medi-Cal and private insurance. Private insurance is at about 3.05 thousand respondents. And then Medi-Cal is at 2.96 respondents.
Yeah, I was looking at that too, Shimar, while during the presentation, and the graphics not set up for percentages, but I think the mental math is kind of like about 30-ish% on Medi-Cal, another 10% on Medicare, and just under 10% with no insurance. So that's roughly 50% or so being on Medi-Cal, Medicare, or with no insurance.
Next question is, can you review the data point related to increased community access and how Monterey County Behavioral Health tripled the number of overall people who access county mental health support?
Yeah, and I mentioned that, but Wes or Shimar, if you want to talk about kind of how we, that methodology of kind of what we're counting there, or I'm happy to fill in.
Yeah, the parameter was within the first year of launch, the amount of people that were seen by Access versus the amount of people that completed the screener. There was a triple number of people that completed the screener versus people who are coming into an Access office. So we're seeing above trifold numbers of people that are accessing information on how to on their mental health, what they're like, almost parallel to a screening that they would get in person when they walk into an Access office. And again, that number of over 80% of people showing that they never have been seen, assessed, sought out support for behavioral health services, or tripling the number of the reach that the Monterey County Behavioral Health Access offices were having in that way.
Is it okay if I ask a question just so that I understand? Thank you. So because it's I think a little confusing how that data point reads, because it sounds like it's tripling the number of individuals who are accessing county mental health support. And so when I think of that, I'm thinking about individuals that are receiving some sort of clinical support from a provider that's either MCBH kind of staff or contract provider, but it sounds like your the frame is perhaps you're utilizing the screening tool to count as county mental health support, but I don't want to misinterpret what what that data point is saying.
I think that's accurate. I mean, I think the idea, you know, it is, I hope not confusing, but it's wording, right? So it's, I understand, you know, what you just described. I think the key is the county, and, you know, Wes, you can comment on this, is you look at your goals in terms of helping people realize, you know, are you really at risk? I mean, a lot of people were not at high risk and went into self-care, and that was helpful. And others are at higher risk and find out where to go. And it may not be with the county. It might be someplace else. So it's mental health support. It wasn't mental health clinical services. You know, we're not saying they tripled the clinical services. It was just tripling the number of people that engage. And as Shimar said, we're talking about completed assessments, not just people that engaged with the website, which is a larger number.
Okay, and I think that the phrasing, because it did say county mental health support, and so I think maybe it could be some of those finer points could be more clear. That would just helps, I think, understanding what happens for individuals as a result of interacting with the tool. And I do really appreciate that there's a larger goal than just getting more folks to county behavioral health, helping people to get the help that they need at the soonest point possible.
Yeah.
And this tool really reduces barriers for that. So anyways, thank you.
No, I appreciate that. And I think, you know, we think of the platform as the counties because it's all customized for them. But I think you're absolutely right. It's the platform engagement, you know, tripled support or however. We'll rethink the language there.
Yeah, I mean, yeah, through the tool, three times as many people sought help than the entire volume of clients that we saw at Monterey County Behavioral Health.
Okay, a couple more questions here. The last few is the age range of users for the tool. So we know it's not under 16, but just the main populace.
Yeah, and again, anyone under the age of 16, you know, if they truthfully answer that and indicate that, then they're redirected to a page on the county website that lists local resources for youth under the age of 16.
And Shimar, I don't have the number in front of me, but it was 16 to 24 was what, 50% of the total users, and then everyone else is.
I'm clicking around to get the accurate information.
I think it was upwards of a quarter of the users to the site were under the age of 16. So like,
yeah,
quite a bit.
Yeah, and then I guess between the about 50% are between age 16 and 35. And then there's a very dispersion for that other quarter of older folks.
So a quarter under 16, 16 to 35, 50%, and above 35, another quarter.
Right.
Okay, hope that helps the questioner.
Okay, thank you. And another one from Sid about how access is defined. I think you guys have approached that subject
Yeah,
matter.
I think, yeah, Wes kind of hit on that in the end of the lesson.
Yeah, and I'll say too, like that results code. So we made this tool be very accessible at the cost of capturing. Well, I mean, it was really a trade-off. It was either we collect personal information and attached to that, there's kind of some stigma, there's some distrust or concerns where people might not want to use the tool if we start asking for names or phone numbers and things like that. Where if we had that information, we could kind of build more integrations with either our clinics or other clinics where the information we shared, and we could reach out directly, say, hey, you know, we know this person called, just the way a lot of companies do using Salesforce. You go to their website, they know you exist and you're interested, so they're going to call you now. You know, we didn't do that because we wanted to have this be very comfortable and anonymous and accessible to people. And so that was a trade-off that we made in Monterey. in terms of how much information we wanted to collect, which was none really, because we want people to be comfortable accessing this tool. So I'm kind of bringing that up because I think, if other counties are interested in this tool and want to put innovation or prevention dollars or anything, any resources to it, there's like Deryk had mentioned, it can be customizable and modifiable, and to work around those things. And so, yeah, actually, I was bringing this up too because as a part of our innovation project, we really only work directly with training up our access clinic staff to work into their workflows, a script to ask about WellScreen, and collect the results code, and so then on their end, those access staff could then kind of make that connection with somebody coming in. And so at least in our access clinic staff, we had a process in place to make that connection, but with our broader community, we didn't really have the resources over the innovation project timeline. So again, I think that's something that other counties could look into further. There is a lot of potential.
Thank you. And then looks like the last couple questions here from Susie. Thanks for your questions. Does the tool just suggest providers, or is there a more robust connection? And then the second part is, has Monterey County engaged with school districts and county offices of education or alternative county community schools?
So go ahead, Shimar.
So our referrals, again, as the name of the game right now, are highly customizable. With Monterey County WellScreen platform, we don't refer to individual providers. We're referring to local programs, and from there, a person can be connected with a provider. So it might have links to various AA meetings, NAMI programs, the broad range of what's available in Monterey County. And then from there, that person can either go, again, referred to Monterey County Behavioral Health itself and be connected to a provider in that way, especially if they meet the criteria of being moderate to high risk and being on medical or insurance. But then people also have the opportunity to get the information to walk into the front door of these other programmings. And then again, there's also the digital piece, the online self-help piece that allows people to see online services that they can engage with, whether that be things that they work on themselves or organizations that can link them to support systems that have clinical services.
And Shimar, let me just add, so that's as implemented in Monterey. Again, this is a project. Let's take a step back. I think the question might have been just technically what's capable. It's a very sophisticated platform. There are APIs. We already, in different use cases, take data and drop them into electronic health records. We can interface with appointment making systems. The key is how sophisticated are the systems that you want us to interface with. The difficulty won't be the transfer of information with this platform. So it's very robust, is the answer to the question.
Okay.
Oh, and then there was the question about interfacing with schools. Wes or Shimar, is the county interfacing with schools now, or?
We kind of spoke to that a little bit earlier. I mean, I think just given that the tool is focused on 16 plus, we're not really heavily engaged with schools on the WellScreen tool. It's more of like a community-wide outreach that we've done and we're doing for 16 plus. But I would say in terms of like working this into our schools or as a part of those conversations, I can't really say that we are heavily engaging the schools at this time.
And it could be where, moving from the screener to the self-care, that the self-care might be more applicable there, for schools.
I think that's it for questions.
We're there. Wow, right at time.
Yeah.
Let me just thank Breaking Barriers again. Elizabeth and Talia, thank you both so much for hosting this and making it happen. Thanks for everyone that joined. You've got our contact information. We'll send out a follow-up email. And thank you, Wes and Shimar and Brittany, for joining us today. Bye, everyone. Happy New Year.